Okay, thank you very much, Rafa, for that introduction. So what I'm going to do today is talk about a few things that I think everybody is aware of OSA and the cardiovascular risk. But what I decided to do is to look at the various phenotypes of sleep apnea, and I'll describe what they are to determine cardiovascular outcomes, and then if the effect of treatment makes a difference on outcomes. And this is important because we kind of place patients on therapies that often they're not compliant with. Now, just to as a aside, I want to say that when I talk about treatment of OSA, I'm going to only specifically focus on CPAP because there are other treatments, but given the vastness of the topic, I have stayed to just stuck to just CPAP treatments for cardiovascular risk and the effect of CPAP on cardiovascular risk. So for everybody who I'm guessing that everybody in this audience knows what sleep apnea is, but essentially there's repeated upper airway collapse during sleep, and there's either a partial or complete cessation of airflow despite the patient making a respiratory effort. That's why it's termed obstructive. There is progressive asphyxia. Finally, there's termination of this asphyxia with a brief arousal and a restoration of upper airway patency. Now, essentially, patients present because of these repeated events of partial or repeated complete obstruction of the airway and effort with loud and irregular snoring. There's gasping or choking. There's restless sleep. And oftentimes they have daytime sleepiness, although that is not always the case. And we'll talk about that as a phenotypic marker. There are other symptoms, essentially, that also patients may primarily present with, which is such as awakening for uncertain reasons and insomnia symptoms, and poor sleep, non-refreshing sleep, and also with neurocognitive changes such as memory, having personality changes, and having headaches and confusion. Now, the classical risk factors for sleep apnea, as everybody is aware, is the male gender, persons in the between the age of 40 and 65, obesity being a major risk factor because there are anatomical predispositions to this obstruction happening. Cigarette smoking increases the edema of the upper airway and therefore increases the likelihood of airway obstruction. And similarly, the size of the neck matters, whether in male or female, again, limiting the anatomical pathways for airway to flow through. Now, this is a pictogram of the pathophysiological consequences of what happens when you have an obstructive event and essentially disruption of sleep and hypoxia. So there's both sleep reduction and fragmentation, which leads to reduced sleep efficiency. Amount of REM sleep is often reduced. There are these arousals, micro arousals, so to speak, to keep the airway open, which results oftentimes in inflammation. And there's a lot of data that shows that. In addition, as I said, there's intermittent hypoxia, and these periods of intermittent hypoxia lead to cyclical events of hypoxemia followed by reoxygenation that leads to multiple effects. Again, very good data that shows that there is increase in inflammation, release of VEGF, NF-kappa B, hypoxia-inducible factor, activation of the endothelial cells and leukocyte adhesion molecules, and has led to an increase in insulin resistance. The intermittent hypoxia itself activates the sympathetic nervous system, both peripherally and centrally, leading to release of inflammatory cytokines, activation of essentially and potentially worsening coexisting heart disease or heart failure. And the intrathoracic pressure setting changes because of the repeated obstructive events potentially leads to increase in LV transmural pressure, increase in afterload, an increase in venous return. So both preload and afterload are increased, therefore increasing the impairing cardiac function, leading to an LV shift of the IV septum and increasing interarterial pressures, also with increased stress on the aortic wall, increasing oxygen demand. And so all of these, therefore, clearly suggest that there is potential significant cardiovascular risk as a result of these repeated events. In addition to the direct mechanical pressure swings and sympathetic activation, there's also direct evidence that there is endothelial dysfunction due to the systemic inflammation, again, the oxidative stress from the repeated intermittent hypoxia, and also increased concern for thrombotic events with activation of platelets and the coagulation pathway. So there's good biological plausibility for concern regarding cardiovascular risks as a result of these repeated obstructive apneic events. So what has been shown, or has been generally the dogma, has been that there are consequences of OSA, including hypertension, coronary artery disease, CHF, atrial fibrillation, strokes, and then in addition, diabetes and metabolic syndrome. But I'm going to go through all of the evidence that exists for all of these consequences and discuss what the data that exists out there, and we can draw conclusions based on this data. Now, to determine the consequences of OSA, we have always used what we call the apnea-hypopnea index. And what do we mean by this? So apneas are essentially a cessation of airflow for at least 10 seconds. There is an associated EEG arousal that may happen, and or a drop in oxygen saturation. Neither of these are necessary for the definition of apnea, although most likely there is often a desaturation event. A hypopnea, on the other hand, has two definitions based on either the Medicare criteria or the American Academy of Sleep Medicine criteria, where there's a reduction in airflow by either 30 or 50% for at least 10 seconds. It's either terminated by an arousal or a 3 to 4% reduction in saturation. Medicare requires the 4% desaturation, doesn't allow for the arousal as a mechanism for definition of hypopnea, whereas the ASM criteria is less stringent, suggesting just a 3% reduction or associated arousal being adequate for a definition of hypopnea. So clearly the apnea-hypopnea index based on the ASM criteria are often more frequent than that of the Medicare criteria. So here is an example of a sleep study. You have EEG on top, you have a chin EMG, you have nasal airflow, chest wall movement, and abdominal movement. And as you can see, there is persistent effort with the chest and abdominal wall. There is absence of airflow, so this is an obstructive apneic event, and associated with that, there's an oxygen desaturation event down to about 85%. Similarly, a hypopnea, in this situation, here's an apnea, but here's a hypopneic event. There's a reduction in airflow. There is persistent effort still, but not so much of a desaturation, but about 3 to 4% desaturation sufficient to call this hypopnea. And potentially EEG arousal, which we're not seeing here, but this was defined as a hypopnea. Now, so when we diagnose or classify severity of sleep apnea, it's based on these events, and we call it the apnea-hypopnea index, which is the number of such events over the total sleep time. And we've classified it basically as mild, moderate, or severe. Really not, it's not clear how this was done. There's a thought that this was just at a conference that it was decided that this was a good idea to do. And so that's how the classification of less than 15 to 30, or more than 30 events an hour came about. Now, remember, so is this classification adequate to determine true severity of the pathophysiological consequences of OSA? And why do I bring this up? Because let's say you have one individual who has an AHI of 60, having very frequent obstructive apneic events, and they do drop their oxygen saturations, but they start at 98 and go down to about 90%. On the other hand, somebody classified as mild, uh, because the frequency of events are much lower, may have a very prolonged apneic event, a significant desaturation event. And so what the AHI doesn't necessarily account for is the duration of time below 90%, that may be important, because remember that intermittent hypoxia has consequences for the cardiovascular events. The prolonged apneic period may be important because of the and the changes in the ventilatory pressures, the intrathoracic pressures, as manifested by an increase in ventilation subsequent to the event, isn't taken into account. And finally, both the depth and duration of these hypoxic events are not taken into account. So it may be that the AHI doesn't necessarily capture the consequences that we are concerned about. Additionally, the sleep fragmentation is another aspect that may also not be captured in such a situation with the AHI. So there has been attempts to change the way we look at sleep apnea, and we've termed this the phenotyping of OSA, because it is complex and heterogeneous, like I said, and that AHI alone doesn't capture the diverse spectrum of sleep apnea. And maybe enhancing the phenotyping may help better prognosticate and personalize treatments. And the way this has been defined by Zinchuk and colleagues was that the patients with OSA, a group of patients may be distinguished from another group by a combination or a single disease feature, and in relation to clinically meaningful attributes, either symptoms or response to therapy or outcomes or quality of life. So that when we look at the cardiovascular risk on the basis of phenotyping OSA, one could look at it not just on the basis of the apnea-hypopnea index, but also on the basis of other potential polysomnographic features, such as the REM AHI, where in REM sleep, there may be much more desaturation events, and maybe that may be an important indicator. Or like I had mentioned, the time below 90% oxygen saturations, called T less than 90, the hypoxic burden, which is the both taking into both account both the depth and duration of hypoxic events, the ventilatory burden, which is the change in ventilation that results in these either the arousal or the hypoxic event. And in addition, there have been assessments of maybe changes in the heart rate that may be important to take into account. Additionally, there has been data that suggests that maybe it's not, that symptoms may be a marker for cardiovascular risk, such as, if the patient has excessive sleepiness, that's a marker for cardiovascular risk, versus other symptoms such as disturbed sleep or minimal symptoms. And obviously, we've seen that age and gender matter, and that the risk changes depending on age and gender. So I'm going to discuss the available data on cardiovascular risk based on these phenotypic features, and discuss the effect of CPAP as well. Now, majority of the data we have is based on the apnea-hypopnea index. And so I'm going to go through the literature on the apnea-hypopnea index and the cardiovascular risk, and show you what the available data is for each, either all of the cardiovascular risks or individual cardiovascular outcomes. So to look at this, there have been a number of observational studies performed, as well as randomized control trials. The observational studies have been in a number of large cohorts, including a majority of the studies coming out of Sleep Heart Health data, which was a community-based study of over 4,000 individuals. Wisconsin sleep cohort, which was again a community-based study of about 1,000 people. And then there are additional studies out of other countries, including Brazil, Spain, France, and then within the US itself, sleep has been studied within a subset of other studies looking at, for instance, osteoporotic fractures in men, older men, called the Mr. Oz study, the MESA study, which was looking at atherosclerotic risk for men and cardiovascular risks in a community, the US veterans, and then the data I'm going to also present is in some large clinic-based studies. So let's look at the apnea-hypopnea index and blood pressure, because there's a tremendous amount of data that supports potentially an association between the AHI and hypertension. And one of the early studies back almost 25 years ago was a cross-sectional analysis of the sleep heart health study, where there were about 6,000 participants studied. And this looked just at prevalent hypertension based on the apnea-hypopnea index. And as you can see here, essentially what they showed was that the odds were highest when your index was more than 30. And otherwise, while even though you had mild or moderate OSA, there was a higher odds of developing hypertension. So presence of OSA, even with mild OSA in this particular study, was associated with prevalent hypertension. What about incident hypertension? Well, this was a study looking at the Wisconsin sleep cohort and again, looking at the AHI. And what it showed was an AHI greater than 15. There was almost a threefold increase prevalence of hypertension, incident hypertension. So these are people who did not have hypertension to begin with and developed hypertension over the study period of about 10 years. And now Wisconsin has gone on to 24 years, and we look at some of the data, but this was looking initially at the 700 odd people after a short follow-up period. Now, similarly, from Spain, there was data that showed that, again, when you followed patients over time for almost 15 years, that compared to those without sleep apnea, the cumulative incidence of hypertension kept increasing depending on the severity of their OSA based on the AHI, with the most severe OSA patients having very high prevalence of high risk of developing hypertension. What about the AHI and coronary artery disease? Well, if you look at prevalent coronary artery disease, and this was a cross-sectional study again of about 6,000 participants from the sleep heart health cohort, the data was not clear that there was an increased risk. This is early data from, again, Sleep Heart Health published early in the Blue Journal that did not show, even in the fourth quartile of AHI, an increased risk for coronary heart disease. Similarly, and I'm sorry for the smallness of this table, but essentially the data was similar with a median follow-up of almost 9 years of over 4,000 patients published in circulation. When you look at the AHI greater than 30, while, if you put in covariance of age, risk, raised BMI, and smoking, there was a suggestion of an increased risk. However, when you added other things like the HDL cholesterol or lipid-lowering medications or the presence of diabetes, or you included the blood pressures and antihypertensive meds, the significance went away. This was in men, and in women, even the univariate analysis did not show any increased risk for coronary heart disease, incident coronary heart disease in patients as a result of sleep apnea. Similarly, the Wisconsin sleep cohort looked at studies looking at following up for almost 24 years here. And again, if you look at the risk stratification based on the AHI, There was a suggestion on increased risk based on adjusting for age and sex. However, when you adjusted for both BMI and smoking, in addition, this risk seemed to disappear. What about OSA and arrhythmia? So there is a good basis for again, increased risk for arrhythmias because of the presence of sleep apnea. Again, the negative intrathoracic changes, the cyclic saturations and desaturation events, and the increase in sympathetic activity can cause acute changes, leading to a reduced refractiveness in the atrium, reduced conduction velocities, and increased triggers that can trigger arrhythmias. Similarly, with the ventricles, increase in QT dispersion and increase in triggers from the hypoxia. And then chronically, because there's remodeling of the atria, there's dilatation and fibrosis, there could be conduction disturbances and hypertrophy and heart failure ventricular hypertrophy leading to heart failure subsequently can also lead to an arrhythmia risk. So let's look at the data out there though. So if you look at the cross-sectional studies, again from Sleep Heart Health, this is a small number of subjects relative to the other studies that were done. This is done by Rena Mara and published early in 2006. She showed that, yes, there was an unadjusted odds of almost five-fold increased risk for AFib, for instance, and for other arrhythmias. But as you started to just for other covariants, including age, sex, and BMI, the one thing that did stand out was both for complex ventricular active. So I'm sorry, I take this back. So both for all arrhythmia events, there did seem to be increased risk for arrhythmiogenesis from in severe OSA. So here they looked only comparing HI greater than 30 compared to somebody with no OSA at all. And here's what the risk was, almost a fourfold increase risk for atrial fibrillation. So the AHI did seem to show with severe OSA that even adjusting for covariance, that there was a higher risk for arrhythmiogenesis. However, when you looked for incident atrial fibrillation, looking at a 5-year follow-up, and this is looking at Sleep Heart Health again, more recent publication, after adjusting for multiple variables, this is looking just for atrial fibrillation. There doesn't seem to be any added risk from looking at AHI as a parameter. What about heart failure? So there was cross-sectional data of almost 6,000 participants, again from Sleep Heart Health, for prevalent hypertension, heart failure. And only in the highest quartile was there an increased risk for development of presence of heart failure. Similarly, if you look at incident heart failure, again, looking at Sleep Heart Health data, this was published in Circulation. It showed that in men, there was, with the highest quartile of AHI, there was an increased risk for a reduction in disease-free survival, as well as in those. However, in women, this was not true. So this data showed that in men, that the highest quartile of AHI, and in this situation it was more than 30, that there was a risk for reduced survival. And finally, the data on strokes. The data on strokes is more significant in that, again, highest quartiles of AHI, hazard ratio of almost threefold increased risk for development of strokes. This was from a single center at Yale of about 1,000 participants in a 3-year follow-up with And again, this was from the Sleep Heart Health, over 5,000 participants, a median follow-up of about 8 or 9 years, showing that in the highest quartile of AHI, there was a higher risk for death from strokes. And so, again, this data was true for men, but not true in women. So there is a gender difference in the risk as well if you just looked at AHI and CHF and stroke. So let's look at, okay, so if AHI may, yes, there's some suggestion that hypertension may be death from heart failure and strokes. There's some data that supports it, but there are gender differences that uh, uh, are present for heart disease alone. There doesn't seem to be good support. Let's look at other phenotypes and see what the outcomes are. So one is the REM-related OSA. REM sleep can lead to an increase in upper airway collapsibility because there's complete paralysis of the upper airway muscles during REM sleep, which can then lead to longer events, a higher degree of O2 desaturation, and in REM sleep, we know there's increase in sympathetic tone as well and a drop in respiratory drive, all of which can lead to those cardiovascular consequences we're talking about, including hypertension, atherosclerosis, and increased mortality from cardiovascular events. When you look at the data that is available for REM-AHI and prevalent hypertension, there is suggestion that this is actually an association, because when you look at data from, again, the Wisconsin sleep cohort of over 5,000 sleep studies, or 4,000 sleep studies from about 1,400 participants, and this is 24 years of follow-up, you see that the odds increases as the REM-AHI increases. And this is specifically, if you look at not only the entire cohort, but if you just look at REM-AHI of greater than 5, of increasing REM-AHI, while the non-REM-AHI was less than 5, this was very significant, especially in those where they had some ambulatory blood pressure data. So it seemed to suggest that REM-AHI by itself has a specific risk for hypertension or the development of hypertension. And again, the risk for cardiovascular events has been examined. This is Nisha Arora, one of my colleagues, who looked at this and published in 2018. And what she showed was that in those who have prevalent cardiovascular disease, when your REM-AHI is greater than 30, and they specifically looked at those people whose non-REM-AHI was less than 5, they found almost a 2 to 3-fold increased risk for the presence of, for the risk for cardiovascular events when you follow them for about 10 years. How about, we talked about the fact that maybe AHI doesn't capture some of those important factors that may actually play a role in the development of cardiovascular events, including hypertension. And one important thing is the duration of time that if you take the total duration of time over the night, where the saturations have remained below 90%, what has been shown, and this is a single study, single center study just published last year, looking at about 775 participants, showing that if you had a greater than 11% period of time where you have these T90 less than 9, time below 90%, you had a 3-fold increase odds for prevalent hypertension. And there seemed to be a linear relationship with increasing time below 90%. Again, shown in both these two figures. And so it seems to suggest that clearly hypoxia plays a very important role for prevalent hypertension. And similarly, if you look at hypoxia or time below 90 in the sleep study and look at heart failure mortality, again, this is a single center study from Germany where they looked prospectively at patients who were in this heart failure center, and they were stable. They had stable heart failure from reduced EF. All of them had a New York Heart Association class of greater than or equal to 2, and they were all receiving guideline-based treatments. They were followed for almost 7 years, and what you see is in the fourth quartile of T90, there was an increased risk for mortality from heart failure. So hypoxia, which is a consequence of these events, does play an important role in potentially uh, hypertension and heart failure mortality. And so the other way to look at hypoxia is what's been termed the hypoxic burden, which is to look at not only the duration of hypoxia, but also the depth. So capturing both the depth to which each event leads to hypoxia. So here in this situation, it starts at 96%, drops to about 85%. So you take that into account, plus the duration of time these events have happened, changing from the baseline, and that has been determined as, and you integrate all of this data and add them up, and that's called the hypoxic burden. And when you look at the hypoxic burden in cardiovascular disease related mortality, this is looking at Mr. Oz. This is the study that's a community based study in older individuals, older men. Again, average of about 10-year follow up, over 2,700 participants. You see that when in the fifth, in fact, there is linear relationship between the hypoxic burden and survival probability. So clearly a relationship between hypoxic burden and a cardiovascular disease related mortality. Similarly, looking at incident heart failure, so not only hypoxia and its relationship to heart failure mortality, but incident heart failure. And here I like this figure because here's a reference. Here the reference is almost no events at all. But if you had somebody who had both a low hypoxic burden, but a very high AHI. And similar to the example I presented, there wasn't an increased risk for incident heart failure. However, when you had a high hypoxic burden, even though your AHI was low, you had a high risk for incident heart failure. Obviously, when you have both as high, that also shows a high risk for heart failure. Now, similar to the hypoxic burden, another indicator potentially that has been studied, or another phenotype, has been what's called the pulse rate response to each of these obstructive apneic events. So what we often see is a drop in heart rate with each of these events of apnea. So you have desaturation event, but in addition, you see this heart rate dropping off and then responding as the airway opens up and coming back to normal. So this change in heart rate has been called the delta heart rate. And so in this instance, there's a small change, but in this instance, there's a large change in heart rate. And so what these authors were looking at is this change in heart rate somehow related to cardiovascular events? And they looked at the MESA database of over 1,300 participants, and they looked at intermediate cardiovascular risk factors. And what they showed was a U-shaped distribution of uh, changes in subclinical cardiovascular biomarkers, meaning that when your heart rate, you either had a low heart rate response or a very high heart rate response, you had increased risk for at least these biomarkers seem to be high. So like the calcium score, the NT-proBNP, and the Framingham cardiovascular disease risk. Now, when they use the same data to look at the sleep heart health study in over 4,000 participants, and they analyzed that, they looked at non-fatal cardiovascular disease events, mortality, and all-cause mortality. And this was again a mean follow-up of 10.7 years, they again show that even when you have, the probability of a non-fatal cardiovascular disease event was high when you have these higher changes or lower changes in delta heart rate compared to mid-level changes in the heart rate. Similarly, data on mortality and all-cause mortality, showing that, maybe the heart rate response is some other way of looking at the consequences of these apneic events. More recently, Ankit from Sinai has done a very interesting and cool study and published just last year in the Blue Journal, where he looked at the breath flow. So basically, ventilation is the primary reason why you have the hypoxic events, or an impairment in ventilation essentially. And so he looked at, well, if you have a normal amplitude of ventilation, but then you have a decrease in this ventilation that leads to what they call the ventilatory burden. And so, for instance, if somebody had an apneic event, they have a ventilatory, a zero ventilation, a zero flow, and that ventilatory burden is extremely high. They looked at a number of normal people. So in the Episonos cohort and the day fun cohort, these are people who didn't have any kind of upper airway obstruction or sleep apnea. They showed that the ventilatory burden was less than 25%, and 95th percentile of the ventilatory burden was below 25%. But if you had OSA diagnosis, then your ventilatory burden was high. When you were treated with CPAP, it dropped again. And then when you were not treated adequately or you came off CPAP, the burden increased again. So showing that the ventilatory burden was a very good marker for obstructive sleep apnea events. He then went on to show that there was a relationship between ventilatory burden and not only all cause, but specific to cardiovascular mortality in the sleep heart health study data of over 4,000 subjects. So here again, looking at each quartile of ventilatory burden, there's almost a linear relationship between survival probability and the ventilatory burden, looking at overall mortality and cardiovascular disease related. So you could also phenotype sleep apnea based on symptoms. And there's been a number of studies that hinted that maybe excessive sleepiness is a marker for increased cardiovascular risk. And so this has been looked at based on doing what they did was a cluster analysis to look at what are the most likely symptoms that a sleep apnea presents with. And essentially what's been shown is that patients with sleep apnea can have 3 to 4 to 7 symptom clusters. And I'll show you data on some of these symptom clusters, but the essential symptom clusters are excessive sleepiness as the primary symptom cluster. Almost 50% of, take people coming into the sleep lab have excessive sleepiness as their primary symptom. But then there are those who have, disturbed sleep without sleepiness as a potential problem, or that they have moderate sleepiness, not severe or excessive sleepiness. And there are those who are minimally symptomatic and they don't have any symptoms, but are being referred because of the concerns that they have severe sleep apnea. So Mazzotti and colleagues in 2019 showed in the Blue Journal that if you look at these symptom clusters and look for cardiovascular risk, what they suggested in their data was that if you looked over time, and I'm sorry for the graphs here, but essentially it shows that the excessive sleepy, which is the red one, compared to all other symptom clusters, seem to have an increased probability for increased probability for new incident CVD. Now, this is, like I showed you, the AHI has never been able to show this. Both CVD and CHD and heart failure. However, it didn't show this for strokes or for death from cardiovascular disease. So they seem to show that coronary artery disease may be related, the symptoms cluster of excessive sleepiness may have something to do with risk for coronary artery disease. However, in France, a study doing something very similar looked at MACE events and looked at your OSA symptom clusters, again classifying them as excessive sleepy, moderately sleepy, disturbed sleep, or minimally symptomatic, and couldn't reproduce that same data in which was shown previously. It's possible that the populations are quite different. Here, this population, they included mild apneics as well, whereas in the previous database, it was mainly moderate and severe OSA patients. And also the way that symptom clusters are performed are different when you look at different studies. Finally, again, looking at symptom clusters, and here's a different symptom cluster. Here they change the cluster designations as having mild or those associated with PLM. So oftentimes when you look at sleep studies, people have periodic limb movements in association with their apneic events. Again, if you have events mainly in non-REM sleep and you have poor sleep or REM sleep with hypoxia, hypopneas and hypoxia, and so on. So these clusters that they looked at based on both symptoms and PSG data, what they were able to show again was that there was an increased risk for cardiovascular events. And this is from a US veteran cohorts database, increased risk both with PLMs, the hypopnea and hypoxia, and combined severe group compared to those with mild symptoms. So again, symptom clustering is another way of looking for cardiovascular events, and that has been started being examined. So what's the data on CPAP in OSA, and what do we have from this data? So let's quickly go over the effect of CPAP on various outcomes, cardiovascular events. Hypertension, treated and untreated OSA, and the risk for hypertension was looked at by Marine and colleagues, and they showed that if you were non-adherent to CPAP or you declined CPAP, but then treated and compared them to a treated group with CPAP, there was a significant reduction in the hazard ratios or odds ratios for the hypertension. And interestingly enough, in 2013, there was a meta-analysis looking at changes in blood pressure in response to CPAP. And the more adherent somebody was, the more likely there was a change in both diastolic blood pressure and mean arterial pressures in subjects. Again, so showing the meta-analysis data on over 1,100 subjects, looking at, comparing sham or placebo CPAP versus CPAP alone. What they showed was that there was a reduction in hypertension when you were adhering to CPAP or with CPAP therapy. In terms of cardiovascular disease, this was an early study that seemed to suggest, so this was looking at a population of healthy people, simple snorers, those with mild, moderate, or severe disease, and those treated with CPAP, and there was a mean follow-up of 10 years, and they looked at fatal cardiovascular events and other major cardiovascular events, and showed that there was compared to controls, if you went on CPAP, that there was a reduction in the cumulative incidence of fatal cardiovascular events. Now, this is observational data. However, when you looked at RCTs, and the first RCT that came out in 2016 that everybody is aware of, the SAVE trial, this was looking at primary prevention of cardiovascular events in OSA. We could not demonstrate that there was any difference with the use of CPAP in this population, looking at over 1,300 people and who were treated with CPAP compared to 1,300 who got usual care. Similarly, for the secondary prevention of coronary artery disease, by looking at a subset with who were not sleepy, the Riccardo RCT again showed no difference whether you use CPAP or you were in the control arm. A third study that I haven't put in here, the Isaac study, similar data on those who had acute coronary syndromes, followed up on CPAP. no difference in outcomes in terms of recurrent events. However, in terms of strokes, there seems to be data that suggests that CPAP actually does make a difference in reducing the incidence of strokes. And this is meta-analysis from a number of studies that was published in 2016, showing that CPAP was favorable in terms of reducing incident stroke and stroke mortality. And then looking at symptom clusters and the effect of CPAP, that same study that looked at symptom clusters and cardiovascular events, if you looked at the odds for things like acute coronary syndrome, TIA, strokes, or death, comparing those with regular or not regular CPAP use, there seemed to be a suggestion that those who had the symptom cluster of hypopnea and hypoxia, there was a significant improvement in these risk odds with the use of CPAP. Now, JAMA just published last week a paper looking at CPAP adherence and the risk for recurrent cardiovascular events. This was a meta-analysis looking at the three trials, the RCTs, the SAVE, RICARDSA, and ISAC. All three trials, and as we had known before, what they showed was CPAP or no CPAP, there was actually no difference in cumulative incidence of major adverse cardiovascular events. What they also showed was the CPAP use, as time went by, it began at about 4 hours, but it dropped off by about a year to about 3 hours or so. Now, when they looked at adherence to CPAP and the risk for recurrent cardiovascular events, so like I said, the median adherence was about 3 hours. However, about 39% had good adherence. And when they looked at the on-treatment analysis, they showed that those who had good CPAP adherence, the hazard ratio for developing an event subsequently was significantly lower. And this has always been the argument we have made, is that if somebody is using a treatment for less than half the time that they require to use the treatment, how do you expect a response to the treatment? And so this data shows that the more adherent somebody is, there's actually benefits from using the device. So what do we have so far? We have shown there is good biological plausibility that sleep apnea can lead to cardiovascular events. I think there's enough data to suggest that there is a strong association of AHI and prevalent and incident hypertension. However, there is not enough evidence to support the association of AHI with either prevalent or incident coronary artery disease, adjusting for other covariables. There seems to be a suggestion that severe OSA as determined by the AHI is associated with prevalent AFib, but not necessarily with incident atrial fibrillation, and that the highest quartiles of AHI is associated with prevalent heart failure and incident heart failure only in men, not in women. Similarly, true for stroke as well. That may be other phenotypes of OSA, such as the REM-AHI or T90 or the hypoxic burden or pulse rate response or the ventilatory burdens may actually be better markers of incident cardiovascular disease events and cardiovascular mortality related to OSA, and that maybe that is what we'd start to be looking at and not just the AHI. However, I don't think can surely state that symptom clusters help us predict cardiovascular risk, and the jury is still out on that. We know that CPAP use does improve blood pressure. I think there's significant data to support that, and including stroke incidence and mortality. And that most importantly, greater CPAP adherence is definitely associated with better blood pressure control and reduces the risk for recurrent cardiovascular events.